Thank you, Nicola, and thank you for inviting me to present and talk to the group today on this really important issue facing left behind communities at the moment, as you eloquently set out in relation to COVID. I've entitled my talk Left Behind and Exiting Early, not to be flippant, but to highlight the fact that the communities that the group here is talking about have been left behind in terms of economic development, but they also, as a result of that, exit early. They die earlier than people in other neighbourhoods. And I'm going to talk through a little bit about why that might be the case, and crucially, what local communities and national government can do together to try and reduce the health burden disproportionately experienced by left behind places. Next slide, please. So I'm going to talk about some of the data from the OCI data dive that was commissioned by the APPG, highlighting a few more of the key indicators as to how health is worse in left behind areas, even compared to other very deprived neighbourhoods. I'm then going to talk through understanding this with a particular focus on why, as a case study, why COVID-19 rates were higher in these left behind areas. I then talk a little bit about what the evidence shows us about how we can level up health in these communities, and then conclude with some general reflections. Next slide, please. So from the OCI data dive, it just pulled out a few examples. It's obviously a very extensive piece of work with lots of information, and I've just picked out some of the headlines which I found most striking. So this is looking on the left-hand side at life expectancy for men and women in the left behind areas compared to the national average and compared to other deprived non-left behind areas. And we can see here that almost all of the left behind areas, 223 of 225, have lower female life expectancy, for example. And this is around 3 years compared to the English average, and just around 2.5 years compared to other deprived neighbourhoods. So there's some extra burden that is being felt in these particular communities. On the right-hand side is a similar chart which looks at healthy life expectancy. And this is a measure which we use in public health and the NHS to think about how long on average we can expect a member of a community to live without a disability. And again, you can see a big division between left behind areas and other neighbourhoods, with very low healthy life expectancies, well below the national retirement age, for example. Next slide, please. The data dive also contains a wealth of information specific to each of the left behind areas that are covered by the APPG. And we can see here that for male life expectancy, it's lowest in Bloomfield in Blackpool and Stockton Town Centre in the northeast of England. So a life expectancy on average of around 67, 68 years compared to a national average of around 82. So these are really stark inequalities that these communities face. People are exiting early, and that's because they've been left behind in terms of social and economic factors. And we can also see similar issues in the same places in terms of healthy life expectancy. So the number of years someone can be expected to live without a disability, for example, in Bloomfield is only 49 years. So this is extremely low. We can see that in more affluent areas, for example, we'd expect that figure to be over 75 years. Next slide, please. It's not just about physical disabilities or mortality and life expectancy. We can also see inequalities when we look at mental illness. And I know the local trust talk later will focus more on this aspect. Here's data from the Department for Work and Pensions, looking purely at how many people receive incapacity benefit or employment support allowance. So it's quite a tight definition of who can receive this support. So probably only the kind of top of the iceberg in terms of the underlying mental health burden in these communities. But again, we're similar pattern whereby it's much higher for people in left behind areas, even compared to other deprived areas, and almost double that of the English average. Next slide, please. Now, health inequalities, obviously as a health researcher, they matter deeply to me from a kind of ethical perspective, and I know that colleagues listening today will also agree. But there are also implications in terms of a wider sense of costs. They have costs to individuals and families in terms of losing a family member and in terms of your own health burden. They matter to communities. Losing people earlier than they should be is a detriment to that community. It's also a cost to society in terms of lost years of contribution and labour productivity. And as a result, it has an economic impact as well. I was involved a couple of years ago with my colleague Luke Mumford with the Northern Health Science Alliance report called Health for Wealth. And here we calculated, looking specifically here between the North-South health divide, we found that around a third of the productivity gap between the north and south of England was a result of the higher health burden in the north. And it accounts for around 13.2 billion in lost productivity per year to the English economy. And we could ascertain from this that there's going to be a similar loss in these left behind areas in terms of the economic impacts of these really stark health inequalities. Next slide, please. As Nicola mentioned in her opening talk, previous session of the APPG looked at the disproportionate impact of COVID-19 on left behind areas. And data from the more recent OCI data dive shows that this is still the case. So looking last year from March through to December, they found that left behind areas had a much higher mortality rate of over 150 deaths per 100,000 compared to deprived non-left behind areas, and obviously a lot higher than the English average. And around half of the left behind areas have higher mortality rates than the national average. And these are particularly focused in my own region of the northeast of England. Again, in some recent work with the Northern Health Science Alliance, we calculated that the Northern Powerhouse had an extra 12.4 deaths per 100,000 than the rest of England during the first wave of COVID-19. Next slide, please. So now I want to touch upon what we know from public health research about what causes these inequalities in health between left behind areas and other areas. And I'll just focus on COVID, as obviously it's the most prescient case study. And I think we can say that left behind communities and the individuals living there have higher rates of COVID-19 mortality and cases as a result of at least 4 interacting pathways. Firstly, they have an increased vulnerability because they have a higher burden of clinical risk factors to underlying health conditions such as diabetes or COPD. They have an increased susceptibility. There's studies, particularly in the past, looking at, for example, annual flu, and found that people had weakened immune systems, partly through long-term exposures to adverse social determinants of health. These are demonstrated in the diagram on the right. So these are things like having poor quality housing or lack of employment. The third pathway is around increased exposure to COVID-19. And here we can touch upon things like inequalities in working conditions, having to go into work as a key worker, whereas other people in other communities, more affluent, are more likely to be protected by working from home, for example. And the fourth pathway is around transmission. And this ties into inequalities in neighbourhood, community and housing conditions, such as lower access to green space and public parks for exercise, for example, overcrowded urban environments, and indeed overcrowded homes, making it much harder for people to self-isolate, as does financial resources that individual households might have. Next slide. So the key question for the APPG, I would imagine, is about what can we do about this? How can we, to use the current buzzword, how can we level up health, getting left behind areas closer to the average? And drawing on health inequalities research more broadly, we can think about 4 different ways, 4 different levels at which we can intervene as a society. The first one is strengthening individuals by giving them more resources to be able to, for example, make healthier choices. The second is through strengthening communities, so enabling communities to design and kind of control their own environment more, for example, by increasing access to parks and public amenities. The third is around improving living and working conditions, so thinking of interventions that can make health at work, the link between how you work and your health, breaking that link, for example, through occupational sick pay or by health and safety legislation. And the fourth one is around promoting healthy policies. So thinking much more around the role that national government can play in supporting individuals and communities by making a framework in which certain activities that are seen as bad for health are restricted. And a key example of this in the UK would be the decades-long evolution of policy, for example, around smoking. Next slide, please. And I just wanted to provide an example because often when I talk about health inequalities, people want to know, when have health inequalities decreased? Where is there evidence that we can definitely do something about it? It seems quite complicated with all these different pathways. And in 2001 to 2002, England had a national strategy which spread across all the different departments, local government and national government and the NHS. And this was one of the most extensive strategies in Europe. And there were decreases during the strategy period in terms of key indicators of health. And these charts just show a couple of examples. On the left-hand side that includes the dotted red line, this looks at what happened as part of this strategy, which included, for example, a lot more investment in NHS and public health services in more deprived areas. They found that mortality amenable to healthcare, the gap between the most deprived 20% of local authorities and the rest of England, decreased during the strategy period. And that was researched by colleagues at Liverpool University. And on the right-hand side, some work that we led from Newcastle University found a similar pattern when looking at mortality rates for infants. So infant mortality rates, which is babies who unfortunately die under the age of year one. No big inequalities, as you can see, a large gap before the period of the strategy in 2000. And this gap between the most deprived and most affluent local authorities decreased significantly during the strategy period. So there are things that can be done working nationally, but also with communities and using different aspects of our local and national infrastructure. Next slide, please. So my concluding comments are that we have very key evidence from the Oxy report and from data and research done around deprivation and health over a number of decades by the public health community that almost all indicators of health and well-being, including mental health, are worse in left behind areas. And COVID, unfortunately, is another example of this. I believe it's to do with multiple interrelated causes that therefore require a holistic and multifaceted intervention strategy working at different levels. There is evidence that we can act to reduce health inequalities, and we had a decade in which health inequalities did decrease. But we do need to think about not just doing work nationally, but bringing communities on board and ensuring that strategies that are directed by Whitehall or by experts also take on board the needs and priorities of communities. So by way of example, it may be from looking at data like the Oxy Data Dive or Public Health England data, we might feel that cardiovascular disease mortality is the most important issue in a particular community. But that community themselves might feel more strongly that actually the mental health needs of their young people are the priority for them and their families. And so combining what the kind of more expert view might be with the needs and priorities of communities could be a good way of going forward. And also thinking about what interventions might help with both of those issues. So from a public health perspective, looking at cardiovascular disease might make us think, right, let's do some smoking or diet interventions. And on the other hand, if you're looking at young people's mental health, you might focus around support and treatment for those individuals. But there are common causal pathways, for example, unemployment, which has a long-term impact on people's health outcomes, including cardiovascular disease, as well as unemployment having a strong impact, both in the short and long term, on people's mental health. So I think by combining the insights from, in a sense, top and bottom, we will be able to design a really strong national yet locally prioritised strategy to reduce health inequalities in the future. Next slide, please. And finally, if you're interested further in anything I've said, these are the references from where the data is within this presentation. And thank you very much for listening, and look forward to some questions.